Started. Hi, everybody, and there's a bunch of people on Zoom today. We're launching a program up and coming that this is a prerequisite for them to start. So some people on Zoom, they're doing their homework, learning about the topics, and then we have a program that dives deeper into each topic. But I'm here today from RVNA Health to talk about Parkinson's disease, and this is like the 101 course of Parkinson's, all the basic topics, nothing deeper, expert, just to give you a glimpse of the world. So tell me about you. Anyone here with Parkinson's? Okay, and everyone who is a caregiver, care partner, spouse, friend of Parkinson's? Or just for information? You have tremors. Okay, we can talk about that too. Okay, good. Well, it's so nice to see you here, and I can't wait to meet you and get to know you further because I hope we can help. And I've been treating patients with Parkinson's for many, many years, as you can see some of my background. And when I came to RVNA Health, no different. I've been seeing more people with Parkinson's, and I hear the same theme. I go to this doctor for that and this one, and they're not communicating. And what do you mean I have to talk about diet and sleep? But who's going to do that? And I'm thinking, well, we have this all under one roof. That's what RVNA Health is. It started out with a couple nurses way back in 1914 that said we need to help our community. We have the resources, and we've developed into an agency that serves hospice and palliative care, rehabilitation in the home and in a clinic, community health, meaning we go out and do COVID shots in clinics and flu shots. We take care of babies and first-time moms that need help. We have personal caregivers, private duty nursing, the whole thing. So that's why the name RVNA Health. And of all of the things we do, this Parkinson Center is like this one little thing there, but that gives us the team. So the Parkinson Center, just got to do the plug, is what we developed to be there for the people with Parkinson's, their care partners. We don't like to call them caregivers, because you may not be there yet, where you're actually giving care, but you're a partner on this journey. The medical team, because we know that the medical community does not know all that they need to know about Parkinson's disease. And we want to be a resource for all of those people. Helen, something I forgot. I have notes on my slides. I'm going to have to do multitask here, but that way I don't have to look at the screen. So the Parkinson Center has many components. Our therapy, we have physical, occupational therapy. We treat in the clinic. We treat in the home. We have exercise classes for when you graduate that are Parkinson specific and led by physical therapists. Those are our exercise classes. And we have free education like this seminar. These are all brought to you by our donors right now. And we have these kind of lectures that'll go on. We'll have physicians that come. These are just a list of some of them that have come. We also host 2 support groups a month. We host one Zoom only on the second Mondays and one in person. But what's special about the in-person one, that the American Parkinson's Disease Association has a Connecticut chapter, they list all of the support groups, by the way. But what we have that they don't is we separate the care partners from the people with Parkinson's, because they have their own vents and they have their own issues and they need peers to work through that as well. Then, social. We like to have fun together. We do some great things. And our boot camp is coming up. Talk to me if you're interested. At the end of the month, we're starting an 8-week series where you come twice a week. One of the days is the topics we cover, but in depth. We have a workbook that you work through, because you're going to come away with saying, well, Kate told me to sleep better, but I don't know if I need to sleep better, and how am I going to sleep better? And the workbook, and we will help you work through, how are you going to take all this data and apply it to your life? That's the purpose of boot camp. It's intensive educationally. And exercise, but exercise isn't intensive. Twice a week is exercise, but every week is something different. Because what's the best exercise? Anyone? Any guesses? Like the best exercise you could ever do? That's a good one. If you like walking, you should do that. It's something that you like to do and will actually do, because I can give you the best thing, and if you hate it and don't do it, it's like taking a bottle of pills and just not swallowing them. What's the point? So we expose you to yoga, tai chi, boxing, strength training, cardio training. What is it supposed to feel like? What are the things that you have to do differently as someone with Parkinson's? So this is a great program, and talk to me about it. But our team is PT, OT, speech therapist, RN, dietitian, social workers, music therapist, chaplain. I mean, you name it, we have it. And we have all these other people on our team. So today, like I said, we're just glossing over the topics because there are so many. Talk to me if we have questions as we go through, and you're more than welcome to take pictures of the slides as I go through if you want to look at. Yeah. Helen, can we get the slides to be any darker? Is that a possibility? You do. Yeah, or dim the lighting. How's that? Oh, yeah. All right. So, Intro to PD 101. What is Parkinson's disease? It is a neurodegenerative disorder, and it's part of the brain is not making dopamine. And dopamine, man, it's a neurotransmitter, but that's the good stuff. It controls our movement, our legs in walking, our hands, and that's the reason for tremors. It controls a lot in the brain as well that's involved in emotions, thinking, speaking. Dopamine, this neurotransmitter, happens naturally in our body, and there's always like a resting level of dopamine ready to go. But you can get spikes of dopamine when you exercise, when something good happens to you and it makes you happy. Any golfers? Any golfers out there? No one golfs? Okay. Well, then my golf example won't help. I'm going to use it, and then you have to think of something else that's analogous in your life. So I'm a golfer, and I don't know why I chase this stupid little ball around 18 holes, because it's so frustrating. But then there's the one shot that's so far and so straight, I think I'm going to quit my day job and I'm going to join the tour. That feeling is dopamine. And because you get that hit of dopamine, your brain says, ooh, I like this. I'm going to come back and do it again. So getting through exercise, and it was tough, but it makes you feel so good. That's a dopamine rush. Solving a problem, I have to sit with my 10-year-old and solve a math problem. I go, oh, eureka, we got it. That's that hit of dopamine. So Parkinson's lessens the level of dopamine, and it doesn't give as much of that hit when those good things happen. So the solution is, well, we have to give your body more dopamine. So the medical treatment now is take levodopa, carbidopa, because it is making dopamine in your body, right? I like to think about you and Parkinson's as two different people. It is in your brain, but your conscious brain is beautiful and normal and fully functioning. It just likes to take over in the things that we don't have to think about. So when we're growing up and we're trying to walk, we really have to think about walking. But nowadays, I could walk, talk, text, carry my kid and groceries, and the last thing I'm thinking about is my steps, right? Because that part of the brain, the basal ganglia, said, I'll handle that for you. We call it the central gate pattern. It says, you think about something else with your conscious brain, and I will handle the walking, because I've been doing that for so long. Well, if you don't have the dopamine to the basal ganglia, the smooth movement changes. So the steps become shorter. The other thing to think about is the dopamine says, okay, ready, set, go. And you take those nice big steps. But if you don't have a really good go signal, okay, go now, no, now, and then it turns into this. Or the stop, I need to stop, but I don't have a good stop signal. And that's just an example with gait and walking, but it's this true with arms and reaching and tremor. Because you're just sitting here resting, you don't have to think about your arm use. So the smooth movement pattern in your brain in the basal ganglia is not getting dopamine, is tremoring. but I bet if you think about it, you can turn it off. So we're trying to say your Parkinson's brain is not functioning, but your brain is. How can we learn to use that brain to compensate for some of those things? How is Parkinson's diagnosed? There were a lot of people here with Parkinson's. So how did you find out you had it? I hope you didn't Google it.
I did Google it.
Oh, no.
Many years, and then deaths.
A DAT scan. Did anyone else just go see the doctor and they said, you have Parkinson's? Well, if it's the right doctor, they are very good at diagnosing. Movement disorder specialists are neurologists that are hyper specialized in movement disorders, of which Parkinson's is the biggest one. They see these patients all day long. I feel like they just have a gut sense, but research shows they are 80% accurate at diagnosing Parkinson's disease on the first visit. If you come back for a second visit, it goes up to 90% accurate. And for reference, the neurologists are only about 40% accurate. But if they're still not sure, they might order special imaging. And the reason for the imaging is maybe to confirm, maybe to see, yes, it's an atypical Parkinson's. Oh, it's not Parkinson's, it's just an essential tremor or a different kind of tremor. Let's make sure it's not a bleed, a stroke, a tumor, right? Those kinds of things. So they have these DAT scans. The DA is for dopamine uptake transmitter. So it is literally measuring the amount of dopamine in your brain. If it's there, it's not dopamine. If it's not there, it's Parkinson's. So there's other ones that are coming out. The Michael J. Fox Foundation is really into researching diagnosis and treatment. They don't really care so much about helping the people right now, but they're helping the future. And so they've helped develop a skin biopsy. Backstory, the dopamine is the issue. There's a protein that folds on itself so that the brain can't make the dopamine, but that protein's all over our body. So they lay you on the table, numb your back a little bit, take a little biopsy, ship it off to a lab and test if those proteins are present. It's confirmed Parkinson's. So it's cool that the technology is coming out, but it is so expensive that they're really only doing it with research or cases that they're really unsure. But just to know,
That was my doctor. He said I have Parkinson's.
count on that, especially if it's a movement disorder specialist. And the other one is they say, well, if you have Parkinson's, you don't have dopamine. Let's give you medicine. If you get better, it must be Parkinson's. And that is an okay way to diagnose as well. So because of the dopamine, that is the main thing that you walk away with. Parkinson's, lack of dopamine. Because of the lack of dopamine, it affects our motor symptoms, our movement. So slower movements, even in the mouth. My brain is working fine, but it may not be coming out the same way. Rigidity, it feels very stiff. Your joints feel stiff, but it's not that you have arthritis all over. It's because of how the muscles are limited because of the dopamine. There's usually resting tremor, not an intention tremor. Because when your brain is saying, I need to go get that cup of coffee, you're thinking about it, so it turns off. It's usually at rest. Those who only have a tremor when they're reaching is usually essential tremor. And we see the walking, the shuffling later on, or the short steps, the posture, and postural instability just means you lose your balance, especially backwards. One of the first tests is you stand there and he pulls you back. You're supposed to take a big step, but it often looks like that. I have to make sure. Non-motor symptoms are the other things that dopamine is impacting in the brain. Later in life, it could change cognition, could. It also, because it's that happiness drug, happiness neurotransmitter, it makes you depressed. It's not you. It's literally your chemistry. Depressed, apathy. Apathy is that feeling like, I just don't want to do that. I know I love coming to the library and reading, but I just don't want to do that today. That's apathy. Or anxiety. You might get some sensory changes, pins and needles. Some people have pain. There's autonomic changes in your body. A big one, they found that maybe 10 years prior to diagnosis, The first symptom is constipation. If the muscles are not moving properly, the internal smooth muscles in our digestive system are not moving properly. When things slow down, things back up. And so maybe looking back, you go, oh my gosh, that might have been my first symptom. Another first symptom, loss of smell. These days, we blame, oh, I must have had COVID. But actually, those with Parkinson's, there's a high population that lose their smell or have a lessened sense of smell way before they actually had something bad enough to go to the doctor for, right? Sleep disorders are very, very common in Parkinson's disease. And we talked about depression and dementia. Yeah.
Hypotension, low blood pressure.
Correct. It's the opposite. So when it's in the case of when I'm sitting down, I have a nice low blood pressure because I'm not working. My heart doesn't need all that effort to get blood. And when I stand up, there's a signal that says, she's going, start pumping. And in Parkinson's, it's saying, say what? And it just doesn't happen. So the blood pressure drops when it should go up. And it can make you feel lightheaded. Dizzy is like a yucky word for therapists because it means everything. This is specifically lightheaded, not, or like seeing spots or it's going black, not vertigo. Does that make sense? So physical therapists are important in the treatment of Parkinson's disease because we assess moving, walking, balance, exercise prescription, strength, motion, and we take our patients through a battery of tests and decide, well, what are the exercises? We are doctors of exercise. I prescribe exercise instead of medication. So one thing we do is we look at balance. I love this picture of the Queen. I'm not going to change it. I've had this up here for years. And the reason I have this is because she's exhibiting great balance right now. Balance doesn't mean I can stand on one foot necessarily. It means that my body knows where gravity is, and if I want to stand up to gravity, I can. That's good balance, knowing where your body is in space and able to to control it so that you can walk and talk and see and climb the stairs with a 3-year-old and the grocery bags because I'm not taking 2 trips. That's good balance. So here she is going down the stairs, a person one hand, looking away from where she is and waving. That's good balance. I want you just to appreciate how complicated balance is. We take it for granted. You see blind people walk around. Why don't they lose their balance? Even though vision is a really important part. When I see the wall, my brain is assuming, well, this must be upright. And if I see the floor, I must be ready to take a step because I must be falling towards it. If I see the ceiling, I know I'm going backwards. Our eyesight is very important in our balance. Well, let's say you don't have that. Good thing we have proprioception. Proprioception, the proprioceptive is our feeling. I feel that I'm on my right foot. I feel that I'm on my toes. My brain takes those feeling from our skin, joints, muscles, and says, oh, if you're on your toes, you should come back. Oh, if you're on your heels, you should come forward. And it makes decisions based off of that. But then someone says, well, I have neuropathy. I don't feel my feet. Okay, you're still upright because of the vestibular system. The vestibular system is the inner ear. Ever heard of like the crystals and the fluid in the inner ear? If it goes wonky, you got dizziness and vertigo, right? That is sensing gravity, whether you're lying down or up. And how you know this is working is if you close your eyes, you know you're still upright. If you're in an elevator and it's going up or down, you can tell, right? Because the pressure is changing, your head is moving through space, even though the walls didn't change, so the vision isn't there, the same sensation on your feet, but you know that's vestibular. So a physical therapist's job is to evaluate balance. I have to find different tests for every single sensory input so that I know how to best prescribe exercises for balance. We talk a lot about walking and how it slows down. And it's not the right thing for me to say, just speed up. but it is important. They did this great study called walking, the sixth vital sign. Do you know what vital signs are? Any nurses here? Vital signs, when you go to the doctor and the nurse says, I'll just do your vital signs before the doc comes in. They check your heart rate, they check your blood pressure, they check your temperature, they check your oxygen, they check your respiration rate. Well, now they're saying we should be checking your walking, because those who walk slowly may need more help in life, may not be able to get out of the house, or they're limited. They can just go to the doctor's appointments. If they need work to prevent falls, they might even, if they go to the hospital, they have to go to a skilled nursing facility and not home. But those who walk faster, oh, good things come to them. You're independent in life. You're less likely to be hospitalized if anything were to happen. You're even less likely to have bad things happen to you. They've correlated this. And you can go through the community and do all you want. And if you're a little faster, you can go to New York City, cross the street, and a taxi won't hit you. Thank goodness, right? So how do we achieve that? We'll talk a little bit about it. Well, by the way, like, what is this one? It's meters per second, not miles per hour. And then 1 meter per second, it's about this pace. It's not crazy. But when I'm talking about walking faster, say I'm going to go for my walk, that's my exercise of choice. Just tell yourself, take big steps. Those big steps will get you to cover more ground quickly. That's speed, right? Miles per hour, meters per second, not faster cadence and small steps, those big steps. So, of course, as a physical therapist, exercise is our passion, right? And we knew it was so important. Exercise is really the most fountain of youth we can get. But they tried to study it specific to Parkinson's disease. So this Dr. Ashlag went through all of the research with humans, animals, and about exercise and Parkinson's disease. And these are some of the things that he found out. He found that exercise makes the neurotropic hormones in our brain that have a neuroprotective effect. It's protecting our nerves and neurons. It's protecting our brain. It's protecting it from those toxins that can expose Parkinson's disease and break down the nerves. It also enhances neuroplasticity. That's a great word for the brain's ability to learn and grow. And you'll see later, literally grow. Especially when you're taking in something to some learning or some kind of experience. So our brains can change over time. It can build new neurons, new connections. Not only can they grow, but they can actually get physically bigger, as they are showing that there's more white matter. Literally, the brain can grow with those in exercise. And this one specifically, aerobic exercise. And if you think, oh, I'm too late. Nope, you're not too late. Even starting midlife exercise has a neuroprotective effect. So in conclusion, there are so many studies that say the same thing. Exercise can slow the progression of PD. It is always a recommendation for people with Parkinson's. Slow the progression. All the medications in the world, all the Parkinson's treatments right now are not targeted at the disease. They're only targeted to manage the symptoms. Exercise is the only thing that could slow down the progression of the disease. But you got to do it right. You got to do it enough. I'm sorry, I was saying it, but I didn't do it. So here's an example. Even it's got to be high intensity. It's got to be hard at some points of the exercise. And they even took some patients that they helped through force, not voluntary. You're not going fast enough on this bike. I'm going to take your legs and make them faster. Or on a tandem bicycle, and the therapist or someone else is pedaling faster for them, taking their legs through this. And they saw a significant improvement in their aerobic capacity, their balance, their function. So What are the benefits? I mean, there's no downside except maybe a little muscle soreness. I love the muscle soreness because it tells me I did a good job exercising the day before. But exercising will improve balance, walking, flexibility, posture. It's even impacting our brain and cognition and our memory and our learning. If you have kids out there and they're just doing homework for hours, say, go take a break, go for a run, go do some jumping jacks, come back, and they'll actually learn a little bit better. It helps with our attention, concentration, coordination, endurance, sleep, and you'll get less falls, less of those freezes, and less depression and anxiety. So exercise is super important. The American Parkinson's Disease Association got together with the American College of Sports Medicine and said, hey, I know Parkinson's and you know exercise. What should someone with Parkinson's do? They need to have an exercise program every week that incorporates this. Of course, this is the goal. This is not maybe what you do on day one, but something aerobic, something strength, something balance, agility, multitasking, and something stretching. At any point, if you want to take out your phone and take a picture, go right ahead. Maybe you can ask Ellen for the slide later, but this graphic is available online. Just search exercise recommendations for Parkinson's, APDA, or Parkinson's Foundation, and it'll come up. So here's the snapshot. Ideally, 3 days a week, 30 minutes aerobic. Aerobic means you got to be out of breath enough to take a breath and not be able to finish a sentence. If you're walking with a friend and you're telling the longest story and you're the only one talking, it's not hard enough of a walk. Okay, same thing if it's on a bike or an elliptical or swimming, and you want to try to get that 30 minutes, moderate intensity. Strength training, hitting all the big muscle groups, the thighs, the butt, the arms, the core, the back, trying to get to each one of those for 2 to 3 sets, trying to make 10 reps difficult enough. And it might take you about 30 minutes to get that routine through. Balance, agility, and multitasking. Even if it's good now, you need to practice it to keep it, because if you don't use it, you lose it. Exactly. So things like balancing on one foot, sidestepping, walking backwards, doing turns, eyes closed, going through an agility ladder. There's ways to hit all of these without spending your life exercising, by the way. And then, of course, stretching. Because of the rigidity in our muscles, it's really important that we don't let them stay there. We need to take our body through these ranges of motion to keep that flexibility. So let me go back. So one way to hit all of those topics is LSVT big. In a Parkinson's 101 class, I would be totally remiss to not mention what this program is. Lee Silverman was a patient with Parkinson's that had a really quiet voice. And her speech therapist came up with this exercise program for the voice about, like very loud, very big, high effort, high amplitude voice exercises. But then a physical therapist said, well, those are just muscles. We have muscles in our body. Let's do the same thing with our bodies, and came up with a protocol. Many research studies later, they found that doing the program literally increases dopamine in the brain to the same effect of you taking your 1 dose of levodopa-carbidopa. How cool is that? Those who keep it up maintain their function longer and maintain their abilities longer, even though the brain scans show that the progression of the disease is progressing, right? That's pretty cool. And it hits all of those topics. To do it all, you're getting cardio, and you're getting strength, and you're doing balance and multitasking, and you're stretching your body. So I'm a mom. I do not have time to do everything. I love 2-for-1 specials. This is a good opportunity to get it all in. And it works by promoting big movements, big amplitude, high effort, high intensity. All the research shows exercise works because of its intensity. And the goal is, if you walk small and I say, come on, I know you can do it, walk big, and you use that other part of your brain, you can walk big. If we do it often enough, and I say, great job, you did it, that's awesome. Another hit of dopamine, we're recalibrating your brain. So you always use big steps. It's crazy. And then salience means that it's important to you. So a therapist usually introduces you to LSVT big. They have to be certified in the technique to know how to use it properly. And we take through our evaluation, what's important to you? You want to be able to take a walk? You want to be able to garden? You want to pick up kids or grandkids? And we turn some of those exercises into functions so that if it's important to you, you actually get more dopamine. You help recalibrate the brain better. And of course, there's tons of other excuses, right? But if you feel like, I know, Kate, I hear you. I know it's important, but I don't know what I'm doing. I don't know where to start. That's what an exercise professional is for. It can be a physical therapist. It could be a personal trainer. I have a link at the end for a free 1-hour course. If you have a personal trainer, say, hey, would you take this course for me just so that you know how to train me better? And they can help that as well. So thinking about physical therapy if you just don't know where to start. But in summary, and then we'll take a little break, exercise is literally medicine. When you exercise, you make more dopamine. That is what the Parkinson's brain needs. Exercising with a professional might help specialize how you should be doing it for the Parkinson's. And the research is 150 minutes a week. If you can go harder, you don't have to do as much exercise. Thinking about, as you walk out of here today, do you have a big posture? Bigger than you think you need? Do you have big steps? Bigger than you think you need? Do you stand up out of the chair really slow? Stand up bigger than you think you need. And that is one thing you can do right now to just start the process of making your movements bigger. Oh, I guess I have more suggestions. I have so many suggestions. When I talked about walking, you don't have to think about my heel hits and then my toe and then my arm. Just take big steps. Your brain has been walking for so long with this body, it knows what to do if you can just think about big steps and everything will fall into place. If you need some ideas for balance exercises, they're right here on the screen. You can start walking, standing on one foot. You could try to walk and turn your head at the same time. Left and right, up and down. If you're not used to it, it's a little tough. Standing together, feet together, eyes closed, and keeping your balance. Again, I picked something to help with this proprioception and the vestibular system. I can't help your vision. It is what it is. Okay. Anything on exercise before we move on? Yeah.
And what's your, or the science of this take on pickleball?
Oh, pickleball is great. Yes, I love that it's a racket sport that is multi-directional. You have to go forward, back, sideways. You have to have a big amplitude hit. Your brain is firing. Where's the ball going? What am I going to do with my body? Okay, where am I going to send it? The strategy of it. So it's really, really great. I don't think later in life we move that quickly often enough. And again, if you don't use it, you lose it. I just had a patient with Parkinson's that we finished our LSVT course, and the last thing he wanted to do was pickleball. So we just broke it down. We practiced running forward, running backward. We practiced running sideways. And then at each session, we started to add forward and a hit, random and a backhand, multi-direction to get his brain and body connected. He did great. Yeah, pickleball is a great, and you're getting your cardio, you're getting your balance and agility. I wouldn't say you're getting your stretching and your strengthening, but that's 2 out of 4. That's what they say. You should stretch before and after. No, that's great. All right, one quick topic and then we're going to take a stretch break. I can't have you sit all day as a physical therapist, right? So another person on our team would be a social worker, and social workers are technically mental health professionals, but they're not from necessarily a psychology perspective, just sitting down and listening. They're trying to help you in your social life, which might include home, community. So they're really good at having those difficult conversations. I have a couple patients like, I don't want to run into anyone here because I don't want anyone to know. You know, things are changing. You need to talk it out. So someone that understands the disease is really good for that. Thinking about life, reflecting back, tips for anxiety, advanced directives, all those hard topics. So advanced end of life planning. I had a colleague that said, when my mom passed away, the best thing she did for us was tell us how to run her funeral down to what dress and jewelry. I didn't have to fight with my sisters. We didn't have to argue. It was all laid out. I know this is so long away, but I've also heard now my colleague's grandma is so advanced that she cannot speak. And now they're all fighting over, well, I know what she wants. No, you have no idea what she wants, and it's too late. So to do it when you're well, this is a really good idea. It doesn't need a lawyer. A social worker is a good one to talk to. And if you have to think like, where do I start? I would think about the 5 wishes. So who's going to help me when I can't make decisions? What care do I want or don't want? How comfortable do I want to be? How do I want people to treat me? And what do I want my loved ones to know? So right now, you could join a support group. Like I said, we have 2 of them. You could find one of these professionals. We have them at RVNA Health. And something you could do is discuss the 5 wishes, whether it's with a family member, an attorney, or a social worker. Okay. There's nothing on the slide because you can't see the answer. We're going to take a test. Interesting. Those who can't stand on one foot for 10 seconds have an 84% increased risk of death over the next 7 years. How's that for motivation? So everybody stand up. I'll count. You keep in your head how long it takes before. Shall we do our right leg first? You have a chair in front of you if you need it. Okay, on your mark, get set, go. Stand on one foot. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. He's still going. 13, 14, 15. Oh, it's coming down. 16. No, 17, 18, 19. Let me make sure. Good. If you're doing really well, close your eyes. 1, 2, 3, 4. Good. Let's do the other foot. On your mark, get set, go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good job. So unfortunately, if you had to use your fingers, it doesn't count. That's a 0. So go ahead, look at your age on the left. Look at men and women. We did eyes open and just kind of make a mental note. How'd you do? Did you pass? Did you flunk? Take a picture and say, that's my goal. I got to beat my age. Oh, I really want to be 18 again. I want to get to 43 seconds. I want to be able to do it with my eyes closed at least for 10 seconds, right? Okay. Another one. Turning around with Parkinson's. If you're thinking about, where is my phone? Who's calling me? You're not thinking about those big steps. So I'm going to time it, and you're just going to turn around in a circle and stop when you get back to me. On your mark, get set, go. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000. Good. The other way. Ready, set, go. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5. Good. I really want it to be under 4 seconds. And at most, it should be 8 steps. 1, 2, 3, 4, 5, 6, 7, 8 quarter steps. But if you could do it in less, that's good too. So average 4 to 5, not so good if you're over 5. Your goal is to make it 4 or less. All right, have a seat. I lied, stand back up. No hands. Can you do it with no hands? You can't do it without hands? Okay. Save your energy. Here's the game. When I say go, you go up and down as many times as possible. I'll do the time. You have to count your own reps. as many as possible in 30 seconds. Without hands. But if you have to do it with hands, that's fine. That's a good place to start. On your mark, get set, go.
You're not actually.
I am. 8. You are halfway there. Keep counting. I know. It's for science. Come on. It's only 5 more seconds. And time. Woo, if you lost count, that would be really good. All right, how'd you do? Find your age. Find green is if you don't hit the green number, you need some work. I'll point you to a physical therapist. If you're in the purple section, you're good. Who's in the purple? Yay, good job. But it hurt like heck. Oh, that's just arthritis. You're not even on there? You're above these?
I think that's
Oh, I know. So then you better at least beat the 60-year-olds, right? Good call. I'm gonna have to find the research and find more slides. All right, I'm so glad we got to get moving a little bit. So the next person on our team is our RN, and their specialty is to help manage medications because we need the meds to do the job, but everything you put into your body has a side effect, right? So your medications might come from your primary care, the neurologist, the movement disorder specialist, and if they're not communicating, you might have a mix that's just not working its best. So the best person, is the pharmacist. They have doctorates now? Pharmacists are like doctors of pharmacy. They, for some reason, love organic chemistry. I tolerated it, but so they're the ones that go, oh, I see you have this one from him and this one from her, but they don't mix. Talk to them about that. Obviously, carbidopa-levodopa is the gold standard because the lack of dopamine needs a replacement. That's what it's doing. But there's other drugs that help the dopamine. Maybe they help the transporter get the dopamine across to the basal ganglia. Maybe it helps the receptor listen more. So those are dopamine agonists like Miraprex. There's a Nupro patch, Requip, amantadine. And just to consider some of the side effects are drowsiness, dizziness. The orthostatic hypotension is the low blood pressure when you stand up and get dizzy. It's a very common side effect, especially with beta blockers, if you have to take anything for your heart. There's other CNS, central nervous system changes, urinary retention, GI slowing down. And you just want to make sure you be careful with your over-the-counter cold medicine or alcohol. And with Parkinson's, timing is everything. Timing your medication at the same time all the time. Timing your food, timing your sleep. Consistency is key. When you keep taking the medication, there's this myth out there that I don't want to start taking medication because then later in life I'm just going to need more, so I'll start later. They've proven that to be not true. Later in life, you'll need what you'll need. So get what you need now, I would say. But I have had patients that are at the end of their rope and they're just, I'm taking pills every hour because dopamine, like in our brain naturally, is transient. It comes on quick and it goes quick. So you need to keep taking the medicine to keep replacing the dopamine and then it gets used, replace it and then it gets used. So that's the frequency and the importance of the timing. So there are things like deep brain stimulation where they go in, touch that part of the brain, turn on a battery, and the electricity stimulates the brain to make more dopamine. That's great. Yes. Both sides? Yeah.
And better to do it actually more earlier now
Right.
than later.
Yes.
Like I was more expected to live and get your body more.
Yeah. Yeah, absolutely. Because that brain, it hasn't been getting it, so it doesn't know what to do anymore. That's a really good point. And for those on Zoom, she mentioned that you had deep brain stimulation earlier and that it might be more beneficial earlier. I can see why people would be like, oh, brain surgery.
You know,
That's
it's
scary.
easy
That's the
and-
end.
and easy.
It's very, very easy. These surgeons love it because it's almost foolproof. The risks are very, very low. It's pretty simple for them. Yeah, I mean, it's a hole in your head. It's awake twilight, but we just had a presentation last week. Dr. Zibley talked about that they're doing it asleep. How nice would it be? You did asleep, and the outcomes are supposed to be better. Yeah.
During it, and skip, and then go back to sleep.
Right. And they talk about what are the issues you have? Why do you want this? Is it walking? Is it tremor? Is it because there are slightly different parts of the brain that they can trigger, and they'll pick one? Is it that you need to get off the medication? So those are two different things. I had a patient very recently that went in for deep brain stimulation. He was in bad shape. And he was of the less than 1% that had a side effect, that there was a very small brain bleed. So they had to stop the procedure. They left the probes in, it was in place, but they were like, I don't want more surgery, because it ended up he was in a nursing facility. He had to go through rehab to get his strength back. And so they go back 2 weeks later and put in the battery, and they go back a couple weeks later and they turn it on. And it's like magical the first time it turns on. So by the time he got better and healed, he didn't need the battery implant. And he is like, I'm not going back because I'm doing pretty well. I'm walking again. I'm talking again. I have my life back. So there was just something about an external device touching that part of the brain that stimulated it and got it better. Really, really amazing. And then, yes.
Question, could you explain medication-induced dyskinesia?
So when you take levodopa carbidopa, it's supposed to lessen the tremor, make you walk better. If you're overdosed, if you're taking too much, it can actually make movements worse. So sometimes it helps your speech and your walking, but you're having these like random movements and uncontrolled movements, different than a tremor, or it could even make your tremor worse. So if the medication, you have to take it so much to get some of the good effect, but then it's just not working anymore. The efficacy window is like so small, it's so hard to hit. Then it's an option to get away from it. So after deep brain stimulation, you still might need to take levodopa carbidopa, but way, way, way less. But then it's a neurodegenerative disease, and you get more and more. Then there's another option called Duopa, which is a pump right into the duodenum, part of the intestine. So it skips the whole swallowing, esophagus, stomach. It goes straight to the source. It's much less medicine. It's absorbed very quickly, and it gives a little pump. 20 minutes later, it gives a little hit, gives a little hit. So you don't have to think about the timing of the medicine because you're getting a constant drip, essentially. That's way, way, way later. You wouldn't jump to there now. So I had on my slide, exercise is medicine. The nurse wants to respond, yes, but so is medicine. Make sure that you're doing it on the right time. Make sure you know the drugs you're taking, how often, what the timing's supposed to be. Take them as prescribed. Don't think, yeah, I'll just take an extra one, or it's okay if I skip a day. It's a good idea to keep a record and to bring it with you to all your doctor's appointments, if they are not talking. And make sure you take extra medicine with you when you travel. Also, heaven forbid, if you had to go to the hospital, they need an order for, Tylenol. Can you imagine the order they're going to need to get levodopa carbidopa? So on the Parkinson's Foundation, you can order a hospital pack, and it comes with a little fanny pack. You can put extra meds in there. It comes with an ID bracelet. It says, I have Parkinson's, I need my meds on time, and a couple other things in there so that, just like you have the go kit when you're going to the hospital to have a baby, you have a go kit with you to go to the hospital if you have Parkinson's. Sleep is so important because that's where our brain solidifies our learning. It does all of our healing in our body, in our brain, and it is disrupted as one of those non-motor symptoms with Parkinson's. So what you can do now is just help promote those good quality sleep and good rhythms. 80% of people with Parkinson's report bad sleep. Either they can't fall asleep, they stay up all night, insomnia. REM sleep disorder is there's movement during the night. I hear a lot, oh yeah, we've been sleeping in separate beds forever because he hits me or he gets up. The other day, my patient said, yeah, I was playing soccer in my dream and I went for that goal and I fell out of bed. So they end up because the body is supposed to be paralyzed at night, but without the dopamine, it's not working properly. So you get these movements that are uncontrolled instead of, so you're like living out your dreams. And sometimes they're violent even. Sleep apnea is another thing, but it does happen with people with Parkinson's, restless leg syndrome, or those unpleasant sensations in the legs. And you get this urge to move them to relieve it temporarily, but it's hard to fall asleep. And daytime sleepiness, 50% of people get this at some point. And you have to think about the medication. Are you not sleeping well at night? Are there other disorders going on? But these are all brain changes. Yeah.
If you do wake up at night, should you just go downstairs and get to work doing something, or should you try and stay quiet and stay in bed?
That's a good question. Let me see. What should you do? I mean, I guess it depends. Maybe if there's medication that can help you sleep. If it's your thoughts, then maybe you need to go and do some meditation and deep breathing and try to come back to sleep. But you do need that sleep. But you're right. If you're like, yeah, I'll wait for another 20 minutes and I'm still not asleep, what could you have done? That, I think it just depends. That's a tough one. So things that you can start doing now, of course, 8 hours of sleep is a luxury that I don't know. I'll get there someday, right? But that makes me feel really good when you get that. And that's what you really need to have all the brain healing and solidify those memories at night. No screens in the bedroom at night, being on the phone or watching TV before you sleep. That blue light actually stimulates you and it's messing up the circadian rhythm where the sun goes down and your body knows, oh, there's no sun, it's dark. So trying to keep that. The bedroom is for two things only, and one is sleep. Moving on. Caffeine, try to avoid it later. I know not to drink it after like 3. Some people say after 1 or 2. Find it, but it's a stimulant. Exercise helps. When you exercise during the day, you sleep better at night, but obviously not right before bedtime. And watch how much liquid you're taking in at night, just to decrease the need to go up and use the restroom at night. And again, consistency. Go to bed and wake up and take your meds, always on the same schedule. And really dark room at night and good light in the morning. Even if you go sit at the window or in the summer, sit outside with that cup of coffee. But the sun, when it hits your skin, stimulates vitamin D production. Vitamin D makes us happy and fights depression. It's important in bone absorption for those with osteoporosis, but it helps set that circadian rhythm that now it is morning time and I am awake. And when you do not have vitamin D being produced because there's no sun, I know it is sleepy time. You can talk to a healthcare provider about your sleep. They do sleep studies. My patient recently said, yeah, I'll do another sleep study. It was put me up in the Ethan Allen Hotel. Are you kidding? And it hooked me up with all the monitors. And he said, just make sure you go to the bathroom before they hook you up because they get really mad at you if then you have to take everything off. So you can do a sleep study in home. They're not as good, but they're good information, or you can do it at a facility. We have some talks on our website about melatonin. Melatonin is just a very natural substance that we already have in our body that helps the circadian rhythm. So it doesn't leave you groggy in the morning. And the pills, they're 1 milligram, 2 milligram, 10 milligram. Dr. Machado said he goes up to 50 milligrams before he gives up on it. I'm not telling you to take 50 milligrams, but it's something to discuss with a provider that's a really safe option to help. Okay, the occupational therapist can do different things for us in different stages as our needs change. They help with rigidity and tremor, that stiffness, and of course the shaking limits maybe our dexterity in our fingers and our fine motor control, and using our fork, chopping for cooking, buttoning, typing, using the phone. So, and it's just related to all of these things that are going on in the body. What they are really good at doing, PTs are good at trying to fix problems. OTs are like, well, let's adapt it for now. So they have really cool tools, wide grip pens, wide forks. There's devices that help with tremor while you're eating, setting up the scene so that it's the right posture and the right bowl and the right cup and the right straw. They're very good at those kinds of things.
What was, sorry, could you go back to?
Yeah.
What is UE strength?
Upper extremity strength. And then LE is lower extremity. So one thing that I see a lot is, oh, I have horrible handwriting now. And that it gets smaller and smaller and smaller and mushed together and you can't read it anymore. So try this. When you have to do something small, like a little button or a zipper, or you got to write out a check, flick your fingers really hard, 10 times. Go, 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 go. Yeah. You see how it doesn't want to go in and out? Really make that fist and stretch it out. Yes. Stretch, stretch, stretch. Boom. Grab the button and go. Grab the zipper and go. Then write it out. So it's just telling your conscious brain, not your Parkinson's brain, telling your conscious brain, hey, I can move my fingers, see? And then you're going to use it to do a task. When you're writing, think about what you want to write. And then instead of writing and thinking about what's coming, think about your letters. Think about the pen on the paper. Think about the big letters. Try to make the last letter as big as the first. Make it a writing challenge, going back to 3rd grade script handwriting lessons, right? And then take breaks and reset. It gets worse as you go. So just take breaks and reset for each word, each sentence, depending. Hand strength, there's putty, there's grippers, play cards, deal cards. This is really good to keep the coordination. And if you're still having issues beyond that, check out an OT. They also come into the home and check out your setup. Do you need a railing here? Where should you put this grab bar in the bathroom? Is it time for a transfer bench? What kind of bench in the shower do you need? Those kinds of things. Okay. So I could talk about this forever. You tell me, when do you want to get out of here? I hope it's not 3 minutes. Can I go for another half hour? Are you okay with that? And if you got to go, I totally get it. Is that okay? All right. So a speech and language path. Yeah. Of course, I understand. Yes. Do we have anything on the chat I need to address?
No, not yet.
Okay.
Oh, wait a minute, there is
you.
one member who
Take
said-
your bag of stuff. So if you need anything, you can contact us and even just getting an evaluation, you know, and see. So the speech and language pathologists, they don't just do speaking. It's everything that is needed to output. It's how does the brain take in information? How does it process information? How does it turn information into words and then get it out? It is also the voice, the muscles. It is also swallowing. So speech can be affected all these different ways. I'm going to go kind of quick. So suggestions, talk louder than you think. You think you're being normal, that's actually too quiet. Be louder, and it's probably normal. Try shorter phrases. Think about the phrase before you let it go. Make sure that person is looking right at you so they can get all of the information. And in your thoughts, think loud thoughts so that it comes out loud. LSVT loud, I mentioned before, but this is the speech therapist's version of LSVT big, which has been proven to help with loudness, articulation, intonation. You know, I walk out of Parkinson's presentations and I think I bombed. No one laughed, no one smiled, but this masked face is just part of it. So we lose like the over exaggerated facial expressions. So this was just one of the programs that helped that. And then I'll get an email being like, this was wonderful. I was like, no one laughed. Really? That's so good. Okay. That's just part of it. Swallowing. If you find that your voice sounds wet, if you have to cough every time you're eating, if you have to take a couple swallows, there could be something else going on, or it could be part of the disease. And then we strongly suggest you just go and get an evaluation because we want to make sure that there's nothing else going on. Don't just deal with it. Go actually get it dealt with. So when we're eating, just focusing on one bite at a time. Do you know the number one cause of death with people with Parkinson's?
Okay.
No,
Aspiration.
pneumonia. Sometimes because of choking or because of aspiration, where something's going down the wrong way, settling in the lungs, causing bacteria, and it's bad news. So play it safe. One bite at a time, small bites, chew well before you swallow. Don't be sitting in the recliner watching the Super Bowl, you know, sit up tall at the dining room table. Straws, people say, oh yeah, we give patients straws all the time, take their meds, but that's too much work to put pills in your mouth and put your lips over a straw, then suck in and then hold it, take the straw out, push the pills back. That's too much. So if you're having trouble swallowing pills, put it in applesauce or some other kind of puree, or crush it up if you can, or talk to the pharmacist about that. And swallow your pills one at a time. And if you notice anything that you have to keep clearing your throat, bring it up. It's something to get checked out. And one of the ways they can check it out is with a barium swallow, where they watch the barium food go down and watch where it goes. Is it going into the right areas? So the speech therapist also works on cognition, and it changes because of the things that are going on in our brain. It changes because there's Lewy bodies in the Parkinson's brain. It happens 20 to 50% of the time, and it could develop into dementia.
What's PWP?
People with Parkinson's. If I kept saying people with Parkinson's, I think I'd have 90 slides. I say it, but on here. So it might slow down your thinking. It might slow down your processing. It's still there. It's still capable. It's just slower. The Parkinson's brain might have difficulty with attention, multitasking, memory in both short-term and working memory, thinking I need to take in this information and make a decision on it. Executive functioning, like planning, visuospatial. It's almost like the world gets smaller. They can only take in this much information because this is so much more. Trouble finding that word. What is this thing that tells time on my wrist, right? Or losing your train of thought. So what can you do about it is keep it active. Again, if it brings you joy, it's even that much better. Have conversations, get on the phone with someone and chit chat, challenge yourself with math, crosswords, Sudoku, go through albums and be like, remember this one? Oh, that was a good day, right? Exercise, believe it or not, exercise helps cognition. And then you go and see a speech and language pathologist to get a cognitive evaluation, and they develop exercises for your brain. Okay, I'm gonna let Monica talk, and I'm sorry she couldn't be here today because she's a great speaker. So let's see.
Registered dietitian here at RVNA Health. So I would love to just take a few moments and share with you a little bit about Parkinson's and how that relates to nutrition. So I really find this most interesting that the best diet that we have to offer with Parkinson's is the Mediterranean diet. I really like to make this clear because unfortunately there is no diet that we are aware of at this time that can truly treat the disease, but we can say with confidence that the Mediterranean diet, which I will speak a little bit about, can delay progression and certainly minimize other complications. Now, what I really want to introduce today is the role of gut health, Parkinson's disease, and how that relates to the Mediterranean diet. So you can see we have this graphic here, and really what I want to show you and highlight is that there are significant changes that happen in your gut with Parkinson's disease. In fact, some research even indicates that the gut microbiome, which is basically this trillions and trillions of live and active microbial species living in your colon right now, it's a good thing, I promise, actually have very different changes as much as 10 years prior to you being diagnosed with Parkinson's disease. And we see that people's microbiome, people with Parkinson's microbiome is much, much different than folks without Parkinson's. And so there's this school of thought like, well, if we can target and use food and nutrition to optimize the gut health, what does that mean for Parkinson's? And the research does look very promising. So we know that when we eat the Mediterranean diet, as you can see sort of highlighted in the blue on this screen, it's very filled with omega-3 fatty acids, these anti-inflammatory polyphenols, very, very high in dietary fibers via nuts, seeds, whole grains, beans. The omega-3 fatty acids are coming from the fish that's so prevalent in the diet. The antioxidant polyphenols are coming from the abundant fruits, vegetables.
To just introduce you to it. I'll speak on Monica's behalf. So she talked a little bit about the microbiome, and there's actually this theory that maybe Parkinson's develops there and then it becomes systemic and makes its way to the brain. It's impacting constipation. Let me see if I can stop it. Delayed stomach, delayed gastric emptying, and SIBO is where, as things get backed up, you're getting different kinds of bacteria. And that's kind of a newish term that needs to be tested, but they're finding a lot of people with Parkinson's have that. And why this is important is when you take your levodopa, specifically levodopa, carbidopa, but levodopa, it needs to be, it interacts with protein. It's almost like the protein takes it from you. So if you eat your scrambled eggs and your levodopa, the carb at the same time, you're not getting enough of the drug to go to the brain. Okay. So when you eat protein at the same time as your levodopa, the levodopa is less effective. And we hear all the time, the physicians don't mention this. Here's a drug. Okay, see you in 6 months, see what happens. They forget to mention, by the way, don't do this with protein, right? And later on, you think, I'm taking my pills 4 times a day. I'm not getting any effect. Well, maybe it's because you're eating it with protein. So then we change the diet timing, and lo and behold, the levodopa is more effective. So this slide shows 30. I've heard conflicting research to an hour. Do the best you can of timing. You might have your eggs. An hour later, you have your levodopa carbidopa, or you take your levodopa in the morning, and then you eat breakfast a half hour to an hour later. And same thing with lunch and dinner. So the summary here, if you have some gut symptoms, talk to a dietitian because there's many causes and reasons and good recommendations that you can do. If you had to follow a diet, you're trying for a Mediterranean diet, which is mostly about unprocessed, plant-rich whole foods. Carbohydrates, they're not bad. Just make sure you're picking the good ones, not the not white bread and pasta, but the quinoa, farro, barley, those kind of grains are really the best. Lots of fruits, lots of veggies, protein, fish. Monica makes me eat so much salmon. I'm trying so hard, but my kids will only eat so much. So salmon is really like A++, and all the other fishes are also very good. And fats, you need to have those healthy fats like avocado oil, olive oil. But I learned from her also that if you're cooking with olive oil, the nutritional benefits get burned off. So olive oil is great as a drizzle. Olive oil is great at low temperature cooking if you want the health benefits. I mean, I know you got to cook with oil. Avocado oil actually has a higher burn point, so you're not going to burn your food as much. Okay, look, we did it. We have 6 minutes. Resources. Again, this was a lot. You're not supposed to be an expert in any of those things, but now you know my medication timing is important, my diet's important, my sleep's important. I think she said something about exercise, and you know where to go to get more information, right? So RVNA Health is a source of information. We can help you do an evaluation. Doesn't mean you're signing up a sentence of 6 weeks of physical therapy. It's just a chance for us to get to know you, your body, your pain points, and point you in the right direction on a one-to-one basis that insurance covers. But there's other things. Parkinson's Foundation has a lot of resources. The APDA has exercise videos. The Optimism Walk is every September. That's a great way to socialize. They also have a symposium coming up in April, I believe. Michael J. Fox has a book out there, the 360-degree guide for navigating Parkinson's. And Davis Finney, I think he was a professional cyclist, right? Olympic cyclist. He ended up with Parkinson's, started his own foundation, and he puts out this textbook called Every Victory Counts. And the Care Partners, Every Victory Counts as a care partner. These are huge books for free. You just have to go on the website. We use them for our boot camp program that's coming up, but right now they're on delay. So you have to put it in. They mail you a free book. If you have a personal trainer and you think they need to know more about Parkinson's, that's at the APGA Parkinsons.org PD Fitness. Personal trainers need continuing ed and they don't like paying for it. So this is a free one. So they'd be happy to do it. Heck, you could apply for a grant for yourself. Say, I need to go to exercise class and I can't afford it. Will you give me money? And the Parkinson's Wellness Fund is there for you. It supports many, many people of different kinds of need and different financial levels. Maybe I need to build a ramp. I need to get my house more accessible. I need exercise. I need treatment. I need you to pay for my gas so I could see my movement disorder specialist. Just ask. Therapy Alliance, this is a great baseline. If you think, where am I in my Parkinson's? Am I early? Am I middle? Am I late? Am I ahead of the curve, behind the curve? Take this. It probably takes about 10 honest minutes and you're answering questions about yourself and your symptoms. And it takes how many years of being diagnosed are you? Where are you in age? And it gives you a good baseline.
I have a question from the chat.
Yes.
Yes, someone would like to know, could you discuss the link between PD and dementia?
Okay, the question on Zoom is, can I discuss the length of
The link.
the link between Parkinson's and dementia? Because of how the proteins called alpha-synuclein fold and prohibit the dopamine from being produced, these proteins end up flooding more in the brain. They are linked to Lewy body. Have you heard of Lewy body dementia? That's what Robin Williams had. So I think it's that these proteins and these Lewy bodies are invading the brain and limiting the connections that we have established. And if you just can't connect the dots, those thoughts don't come, and that turns into dementia. So down at the scientific level, I believe that's the best way I can describe it without getting a neurologist in here. But it is not everybody. It is usually much later in life. You can see some of those things like, oh, what was that word? Those kinds of things. I hope that answers the question.
Another question is, my doctor says that I don't qualify for DBS because I have cognitive loss. Is this a universal opinion or is this one doctor's point of view?
Okay, the question was, my doctor said I don't qualify for deep brain stimulation because I already have cognitive loss. If this everybody's perspective or just this doctor's, it is always worth a second opinion. There are some DBS specialists that are doing it differently, have seen it on different patients. And in the end, if it's your life, it's your quality of life, it's a low risk procedure. So if it's no effect, I mean, it is brain surgery and you're not going to get an outcome, but it's absolutely worth a second opinion because who knows, maybe it could help it. Maybe the cognition is only part of the puzzle and physically you're not moving well enough to live and enjoy your life, and it's worth that sacrifice. But the deep brain stimulation is not, even though it's easy for the surgeon, it is a big conversation with a multidisciplinary team, and they'll all make the decision. It's not going to be one guy's thought. Anything else? Look at that, 2:14. I was told 2:15. So I'll hang around if you have any questions. Thank you. I hope you got at least a tidbit of something that you're going to go home and investigate more. And when you feel like you need help down that path, we have the resources you need. So reach out to us, come on in. If you're interested in boot camp, let me know. That's it.
Already done with Alice.
Mhm. The 4 weeks, 4 times a week, good. Yes, absolutely. So we have that class every Monday at 1:30. And it's a great group of people, and it's just people with Parkinson's. And we use those maximal daily exercises, but then add a twist. So maybe we'll add some weight, we'll add some cardio to it. We'll all do walking together, and because they get stale, but they should be, once you learn it, you should do them every single day. Oh, no. So at least you could have like once a week in class and maybe another time at home. But I know people that when I go away and I don't do my exercise, I don't feel as good. But you could do it in the hotel. There's really no excuse. So it'll definitely keep you on track. You could do it on Zoom. Yeah. LSBT has, yeah. Yeah, where you buy the video, there's a video download. So yes, please come. Yeah, you don't have to, we can get you.